Good afternoon, everyone. Thank you so much for joining us. I'm going to start by saying a few words as people continue to roll in here. My name is Winnie Armand, and I'm a physician at Mass General in the Division of General Internal Medicine and a member of the Mass General Center for the Environment and Health. Welcome to today's webinar, our monthly webinars that we are hosting with our colleagues at Mass General Institute of Health Professions, the Center of Climate for Climate Change, Climate Justice, and Health, for this educational series on the important intersection of climate, the environment, and healthcare. It's really inspiring to see hundreds of you registering from across the country for our Grand Round series to talk about these really important issues in healthcare or sustainability. Just a few housekeeping issues. There is closed caption available, so you can select that on your screen. In addition, this webinar is going to be recorded and it will be emailed to you with a link shortly after this session. And I'm going to have to just acknowledge the incredible amount of work that Michael Busnek has put into this to make this seamless from beginning to end. Please also note that the chat function should not be in use, and instead you can submit your questions at the bottom. There's a Q&A. So throughout this hour, feel free to enter your questions. And at the end, with whatever time is left, my colleague Barbara Bellinger will be moderating those questions. At this point, I'm going to turn over the mic to my colleague, Patrice Nicholas, who will introduce herself, as well as our esteemed speaker. Thank you.
Good afternoon. I'm Patrice Nicholas, professor at the MGH Institute of Health Professions and director of the Center for Climate Change. And I have the distinct privilege of introducing Dr. Philip Landrigan, our speaker for today. Dr. Landrigan is a pediatrician and epidemiologist who directs the Program for Global Public Health and the Common Good at Boston College. He is a member of the National Academy of Medicine. Dr. Landrigan's early studies focused on lead toxicity and were conducted while he was with the CDC. These studies demonstrated that low-level exposure reduces children's IQs and contributed to the EPA's 1975 decision to remove lead from paint and gasoline, and actions that reduced lead levels in the United States by 95%. And increased the IQ of all American children born since 1980. Dr. Landrigan chaired a 1993 National Academy of Sciences study that defined children's exquisite vulnerability to pesticides. It recommended revamping US pesticide law to better protect children's health. The findings were incorporated into the Food Quality Protection Act of 1996, the only federal environmental statute containing provisions to explicitly safeguard children. Dr. Landrigan served on the faculty of the Mount Sinai School of Medicine, where he chaired the Department of Preventive Medicine from 1985 to 2018. He also oversaw the medical follow-up of 22,000 9/11 rescue workers. In 2015 to 17, Dr. Landrigan co-chaired the Lancet Commission's study on pollution and health, which found that pollution causes 9 million deaths annually, and that pollution prevention is feasible, cost-effective, and saves lives. Since 2019, Dr. Landrigan has led the Monaco Commission on Human Health and Ocean Pollution. He's a graduate of the Boston Latin School, Boston College, Harvard Medical School, and the London School of Hygiene and Tropical Medicine. Dr. Landrigan, thank you for joining us today.
Thank you, Patrice, and many thanks to all the good folks who organized and made this possible, especially Michael, who is the wizard behind the curtain, who is making the slides work. So here's my topic today: pollution, climate change, and health. And oops, sorry, wrong button. Here we go. Okay, so my overarching theme this afternoon is that the environment is a very powerful determinant of health and disease. Too often, unfortunately, in clinical practice, it's overlooked. But I'm going to try to persuade you in the next 45 or 50 minutes that the environment really is something that you should consider with every patient whom you run into. And for those of you who work in public health, you know already that the environment is a powerful shaper of health and disease. So over the past century, there have been two big changes in this country. First of all, a change in patterns of disease, and at the same time, a change in the environment, specifically in patterns of exposure. So in terms of disease, back in 1900, the average life expectancy in this country was less than 50 years of age.
Excuse me for interrupting, Dr. Landrigan. I'm not seeing your slides. Are others seeing the slides?
That's correct. I don't think we can see your slides.
Oh dear, okay.
Thank you. Thank you, Phil.
Give me a minute here to see what's going wrong. Oh, I bet what happened was when we put the introductory slides up, I lost my
Yes.
screen, I lost my screen sharing. So just a second, I have to find that. Bear with me.
Yes.
Would it be helpful if you would like?
Wait a minute, I've got it
Oh.
now. Here we are. Are we sharing now?
Terrific, Phil.
Okay, sorry about that. And you can see my slides now, okay?
Yes, it's not in presenter mode, but we
Now
can
it
see.
is.
Okay, now it's great.
Yes.
Okay, sorry about that. Excuse me, everyone. Okay.
Thank
so
you.
I was starting to say that in the past 100 years, there's been a profound shift in patterns of disease and death in this country. The background 1900, average life expectancy was about 47 or 48 years. Today, of course, it's around 80 years. We've had huge declines in infant mortality. The infectious diseases are certainly still with us. All you have to do is remember COVID-19, not to speak of Ebola and SARS and AIDS, but nonetheless, infectious diseases do not have the powerful impact on mortality that they did a century ago. And instead, it's the non-communicable diseases, heart disease, stroke, cancer, that have become the major causes of disease, disability, and death. And this switchover from a pattern of morbidity and mortality that is dominated by infectious diseases to one that's dominated by the NCDs is referred to as the epidemiological transition. Now, at the same time, we've had a huge environmental transition. Some things are good and some things are not so good. On the good side, air pollution, which peaked in the United States and Western Europe in the first half of the 20th century, has fallen by 70% since we passed the Clean Air Act in 1970. Air lead levels have fallen by more than 90% because of getting lead out of gasoline. But at the same time, chemical pollution, plastic pollution, pollution of the oceans have all been getting worse. And then, of course, we've got climate change, which is intimately linked to pollution. So let me delve a bit more into those, and specifically, let me explore with you the consequences that all of these have on human health. So let's start with a little history. This is the epidemiologic transition in New York City. The original of this slide hangs in the office of the New York City Health Commissioner, modestly titled "The Conquest of Pestilence in New York City." So this graph covers from 1800 over here on the left, if you can see my cursor, over to 1980. And the line, the jagged line that goes from left to right across the slide is the crude death rate, the number of deaths per 1,000 population in New York City. And there are several lessons that you can take out of this slide. Firstly, you can see that in the 1800s up until about 1880 or somewhere in there, that the background death rate here was much higher than in the 20th century. And the reason for that, quite simply, is that people only lived half as long on the average. Many babies died in the first year of life, infant mortality. Women died in childbirth, and people died at relatively young ages of the infectious diseases. And then superimposed upon that already high background death rate, you see these terrible spikes representing epidemics: cholera, yellow fever, smallpox, typhus, that swept in to New York and Boston and Montreal and Philadelphia and all the other big East Coast cities around that time as the waves of immigrants came in from Europe. So, for example, this terrible 1849 outbreak of cholera, where the death rate was up around 5% of the New York population died in that year. That's when the great wave of immigrants, including my ancestors, came in from Ireland, carrying cholera with them in what were called the coffin ships. And if you, just to give you a sense of how massive was that die-off back at that time, so the death rate was 50 per thousand, which means that 5% of the population of New York died in a single year. Today, with a base population of around 8 million, that would be 400,000 deaths in a single year if it were to take place today. So you get a sense of the powerful impact that infectious diseases had back in that time in history. And then starting right after the Civil War, 1866, the Board of Health was established. It took them a few years to get up and running, but over the next 20 years, they did some massive changes in the environment. Specifically, they built reservoirs, they built aqueducts that brought clean water into the city, they built sewers to take out the waste. They passed legislation which limited the number of people that could be crammed into an apartment. And all of those environmental factors greatly drove down the death rate. And you can see it starts here around 1880, 1890, and continues down to 1940. All through that time, the death rate is declining. Now, what's interesting is that antibiotics really didn't come along until about 1940. First the sulfa drugs and then penicillin. So this big decline in death occurred well before the advent of penicillin, certainly long before the first kidney transplant, the first heart transplant, the first intensive care unit. So it's really quite amazing that man-made environmental change on a massive scale was a powerful driver of health and disease during that time. So just breaking that down, these are the factors that influence the epidemiologic transition. On the positive side, clean water, sewage, immunizations, public health infrastructure. And on the negative side, all of the evils of the 20th and 21st century: tobacco, alcohol, drugs, sedentary lifestyle, and then the factors that I want especially to talk about today, which are pollution and climate change. So what has happened since the epidemiologic transition is that the non-communicable diseases are going up. And because I'm a pediatrician, I'll look particularly at children's diseases, but a very similar pattern is seen for heart disease and stroke and chronic obstructive pulmonary disease. So here's asthma, which has tripled since we started tracking it in the 1980s. Here's childhood cancer. The good news on childhood cancer is that the death rate is way down, thanks to chemotherapy, which began in the 1960s. So I was a pediatric resident at Boston Children's from 68 to 70. Back in that era, every child with cancer died, no exceptions. Some of them survived longer than others, but they all died mostly within a few weeks to a few months. Today, 85% of children with leukemia survive. 50+% of children with brain cancer, which is the second leading pediatric cancer, survive. But on the negative side, the incidence of leukemia and likewise the incidence of childhood brain cancer have both risen approximately 35 to 40% since the 1970s when we started keeping records. And that threatens to offset all the gains, all the magnificent gains we've made in treatment. And it's clear that it's too rapid to be of a genetic origin, there must be something going on in the environment or some combination of things more likely that is driving this change. Likewise, testicular cancer in young men has increased by 55% since the early 1970s. And at the same time as testicular cancer has been going up, birth defects of the male genital organs have been going up. These are CDC data looking at hypospadias and epispadias in the greater Atlanta area. And you see that there's about a 50% increase in the occurrence of those conditions. Neurodevelopmental disabilities, especially autism, have been going up. To be sure, some of this is better recognition, better awareness, more specific diagnoses, but underneath that, those recognition factors, there's also a true increase going on in autism and attention deficit disorder. And then we have this terrible problem of obesity, which has gone up from around 5% among American children in the 1970s to close to 20% today, with big disparities by socioeconomic status and race and ethnicity, and terrible consequences for health, disease, quality of life, and life expectancy. So here's the key question. This is really the centerpiece of this talk today. What's the contribution of environmental factors to these rising rates of non-communicable diseases? And let's dig into that. So I want to start this part of it by talking about the Lancet Commission on Health, which Patrice mentioned when she introduced me. This report was published in the Lancet in 2018 for those who wish to download it. We define pollution as any material introduced into the environment by human activity that endangers human health or harms ecosystems. By the way, just as an aside, this picture of this horrible pollution that you're looking here, this is not in some faraway place. This is in the United States. This is actually Cleveland, Ohio in 1968. And this is the kind of air that we had in this country before we passed the Clean Air Act of 1970, just to give you a sense of how far we've come. We've certainly got further to go, but we've made a lot of progress. So that's the definition of pollution. And in the Lancet Commission, the main data source that we used was the Global Burden of Disease study, which is published by the Institute for Health Metrics and Evaluation, which I suspect many of you know about, based at the University of Washington in Seattle. We also cross-checked World Health Organization data. We divided pollution into two broad categories. Traditional pollution is household air pollution from indoor cook stoves, and water pollution, fecal contamination of drinking water. Modern pollution is ambient air pollution and chemical pollution. I realize that that's not a clean division, that there's always been ambient air pollution, but still ambient air pollution and chemical pollution are the hallmarks of industrial development in our time. We also did economic estimates, and we thought it was very important to bring in economics into this analysis, because we reckoned that if we wanted to persuade policymakers that they had to do something about pollution, it would not be sufficient just to talk about disease and death, powerful as that is. We also had to demonstrate to policymakers that pollution costs money and that pollution control is highly cost effective and saves money. And all of the estimates we did are conservative. There are some conservative assumptions built into the structure of the Global Burden of Disease study, and so the numbers that I'm going to present here are large. They're very large, in fact, but still they are undercounts of the full burden of disease and death. So here's what we calculated. We calculated that pollution kills 9 million people per year. We just updated the analysis a few months ago. There's another paper in review at Lancet now, and although there have been some internal shifts from countries to countries since the previous report, the bottom line is pretty much exactly the same, that pollution kills 9 million people per year, which is 3 times more deaths than AIDS, malaria, and tuberculosis combined, all put together, and 10 times more deaths than war and terrorism and violence. So here's a little graph that portrays that on a global scale: war, murder, road accidents, malnutrition, drugs and alcohol, AIDS, salt, tobacco, and here's pollution. Only hypertension and dietary factors considered in the aggregate kill more people each year than pollution. So let's a couple of vignettes about the various types of pollution. Ambient air pollution is the worst one, kills between 4 and 5 million people per year. This is a picture from India during one of their terrible pollution episodes in New Delhi. Household air pollution from indoor cook stoves is killing close to 3 million people per year. This particular picture is from India, but you could get a similar picture from Central America or Sub-Saharan Africa. People, usually women, so there's a real gender disparity here, usually women, sometimes kids, cooking with charcoal and wood and straw and dung, what's known collectively as biomass fuels. Then we have polluted water, which is a combination of fecal pollution and chemical dumping. And then we have polluted soil, heavy metals, which totally, in total, kill about 1.1 million people per year. This is a vignette of a man in, I think it was in Jamaica, using a hatchet here to break up old batteries to extract the lead, which will then go into a furnace and be recycled. And you can see he's got no respiratory protection whatsoever. Very frequently, these facilities are located right adjacent to residences, so women and children are exposed, not just the workers. Okay, turning now to chemical pollution. Chemical production has increased very steadily since the end of World War II. It's basically gone up with a few dips at an average rate of about 3 or 3.5% per year. And it's on track to double by about 2040 over what it is today. And plastic pollution is going up at pretty much the same rate, if anything, even more rapidly. And I think most people think that when they go to the store, when they go to Walmart, when they go to Target, and they see, or they go to a lawn and garden store and they see stuff neatly wrapped in packages, that somebody in the government is looking out for their welfare, checking these products to make sure that the chemicals in them are safe. I would like to disabuse you of that notion. In fact, there is very, very little scrutiny over chemicals before they come to market. What happens is that the very bright engineers, chemical engineers in the chemical industry, come up with new products. They bring them out with great enthusiasm, put them into all sorts of consumer goods. Here's an old ad from, I think, National Geographic. DuPont cellophane, saying the best things in life come from cellophane. Here's another favorite chemical, DDT. What's going on here? This is a mosquito truck in the 1950s, spraying DDT at Jones Beach outside New York City with the little kids running through the cloud. Here's an ad from Union Carbide saying synthetics, they spell a better life for you. What typically happens is that these chemicals are brought to market, put into products, get out there into consumer goods, and then time and time again, they are found to cause harm to the environment and to cause people to become sick and to die. Some of the early examples from a couple of generations ago were DDT, asbestos, the tetraethyl lead that we put into gasoline. More modern examples of chemicals that have been put out there with really very little due diligence before they went to market have been phthalates, bisphenol A, brominated flame retardants, organophosphorus pesticides, all of which are used in quantities of millions of tons per year and that have been subjected to almost no toxicity testing. Here's a graph showing the increase in plastic production, which is more or less tracking with chemical production. So what are some of the links between pollution and non-communicable disease? Well, it turns out very different from the way it was 50 years ago when household air pollution and water pollution predominated. Today, 70% of pollution-related deaths are due to non-communicable disease. And it's about a quarter of all cardiovascular and stroke deaths. It's half of COPD deaths, and an amazing 40% of lung cancer deaths, which really surprised me because I would have thought that tobacco was 90% of the story, but it's not. There is a very big intersection between pollution and poverty and injustice, such that 90% of deaths caused by pollution occur in low and middle income countries. And the injustice here is that so much of the pollution, so much just like climate change, is generated in the high income countries, but the impacts fall very heavily, disproportionately heavily, unfairly on people in low income and middle income countries. And it's even in wealthy countries, even in the United States, for example, pollution disproportionately affects the poor and minorities and the marginalized. This is just a map illustrating graphically what I just said. I mentioned that we did economic analyses, and this was not easy information to dig up. So when you think about it, it's fairly easy to figure out what it costs to control pollution. The people that own a coal-fired power plant down in West Virginia can tell you pretty much to the penny what it's going to cost to install a stack scrubber, what it's going to cost to run that stack scrubber every year. Those are easily measurable costs. And by contrast, the cost of pollution itself and pollution-related disease are not easy to pick up because they're spread out across the population. Not all cases of disease occur immediately. Instead, they occur after a latency period. The costing information is not neatly collected in any one place. The damage to ecosystems is tracked by EPA, but not necessarily linked to pollution. The damage to human health is buried in healthcare costs. It's buried in hospital costs. It's buried in labor statistics that measure lost productivity, but again, not collected in one place and not properly ascribed to pollution. But when you dig into it, and pull it all together, as our economists did, the economics team led by Professor Maureen Cropper at the University of Maryland, the costs are very great. And we find that in high-income countries like ours, the healthcare costs of pollution-related disease are about 1.5% of the total health budget. But when you go to developing countries, and the best data we could find came from Sri Lanka, so you have a combination of high levels of pollution, a lot of exposure, 7% of healthcare costs are based on that. And then the productivity losses that result when people are made sick by pollution, they're taken out of the workforce by illness or death, are another 2%. And these costs amounted in the aggregate to something like $6 trillion in 2015, which is the year we did the computations, which is 4.5% of global economic output. That's a lot of money by any standard. And those costs are so great, especially in poor countries, that they can pull down national trajectories of economic development. So let's talk about the linkage now between pollution and climate change. It's very important to understand that pollution, especially air pollution, and to a lesser extent chemical pollution, originates from exactly the same source as climate change, and that's fossil fuel combustion. Fossil fuel combustion is the major cause of particulate air pollution. It's the major cause of air pollution by oxides of sulfur, oxides of nitrogen, and of course, it's also the major source of the greenhouse gases that are driving climate change. The good news is that anything we do to prevent pollution will slow climate change and vice versa. This is the so-called double benefit, sometimes referred to as the co-benefit of controlling pollution and controlling climate change. Let's say a few words about the history of climate change. This will be familiar to some of you, but it's important to lay out and just really get a good, clear look at what's going on here. So basically, for the last 800,000 years, atmospheric carbon dioxide levels have certainly fluctuated, but they have not been as high as they are today for almost 1 million years, since the time the dinosaurs walked the earth. And this increase has occurred, as you can see from this graph, incredibly rapidly in geologic time. And it has driven this increase in global mean surface temperature. So that previous graph was measured in hundreds of thousands of years. This is measured in decades, so it's on a very different scale. And you can see that the increase in global mean temperature has been quite steady. This curve tracks 4 different databases that I've listed here. And you can see with some minor variation, they all track very closely together. And the finding is inescapable that the Earth is getting warmer. All you have to do is go outside this summer in many parts of North America to experience that, or Europe. And Johan Rockström, who's at the Stockholm Environment Institute, has come up with this concept that there are planetary boundaries. They sometimes get referred to as safe operating limits. That if humans are going to thrive, if human civilizations are going to prosper on the face of the earth, we have to stay within boundaries in these various domains: climate change, ocean acidification, change in land use, and so on. They're listed around the perimeter of this graph. And the folks in Stockholm have done their best to track where we are in these different domains. They say that in the case of nitrogen cycling, we're already way beyond the safe operating limits, and we're getting there with phosphorus. We're getting there with climate change. And then in the case of biodiversity loss, we're losing species at an alarming rate, and it's just not sustainable. You'll notice that chemical pollution, they've not tried to quantify because there are just too many unknowns, and likewise for aerosol loading in the atmosphere, which are really the topics that we're focusing on today. So climate change and health. How does climate change affect health? A little editorial aside here. I think one of the big communications failures of the last 25 years in the climate change community is the failure of the climate science community to persuade policymakers, persuade people that climate change matters. I think the reason for this failure is that the scientists who do the atmospheric modeling and who track the CO2 levels and track the global temperature have just not been able to explain to people why climate change matters in their day-to-day life. And without being able to explain that to people, they can't explain it to policymakers. Now, I think the events of the last couple of years, the wildfires in California, the heat waves in Europe, the rising temperatures in Siberia and Alaska and northern Canada, are suddenly driving it home to people that climate change really does affect them here and now. But it's taken a long time, and we lost several decades or more during this communications gap. I'm hoping that through seminar series like this at MGH, we can close that gap in understanding, make healthcare providers, policymakers, the general public, really understand that climate change is a dire threat to human health, human civilizations here and now. So some of the consequences of climate change: violent storms, rainfall, floods, rising sea levels, melting ice caps, droughts. There's a lot of evidence that climate change is magnifying the health impacts of pollution. When the temperature rises, we burn more fossil fuels to run the air conditioners, and that increases air pollution. Floods cause chemical spills. We saw that big time after Hurricane Katrina in New Orleans. And warmer growing seasons force farmers to increase their use of toxic pesticides. Rising sea levels. This is New Orleans during Katrina. I worry about other cities. There was a big article in the New York Times last week about Chicago as Lake Michigan rises and there's a flow problem with the Chicago River. I worry about Boston with all the development on the South Boston waterfront in Charlestown. Many of that about 1 foot above mean high tide. What's the effect of sea level rise on coastal populations? Well, flooding, erosion, loss of land, contamination of fresh water. What happens is the salt water intrudes into the aquifers and they become brackish, chemical spillage, and people have to move, especially in low-income, middle-income countries, people that depend upon the sea for their livelihood. If they can't live near the ocean and they have to move inland, they become climate refugees. They bring with them malnutrition, disease, potential for civil unrest, even the potential for war. Wildfires, which cause respiratory illness, and burns, and death. This is India. As the snowpack in the Himalayas shrinks, there's less runoff in the spring, and here is a burned out river that's providing no useful water. Drought in the American Southwest. Famine, poor crops, waterborne disease, increased range of the mosquitoes that carry malaria, dengue, other vector-borne diseases. You can see if you look at the southern United States that there's the real danger that dengue could become endemic along the Gulf Coast in not too many years. And then you have refugees. So that's the bad news. What's the way forward? Well, the biggest single thing that our society can do to make a difference against both air pollution and climate change is to transition as rapidly as possible to clean, renewable energy, which by that I mean solar energy and wind energy, like as is exemplified by this huge solar array that you see in this picture here. Key message here is that pollution can be controlled. It is not inevitable. It is not the unavoidable price of economic progress for developing countries. The fact that countries like our own, Western Europe, Japan, Australia, have made excellent progress against pollution is proof of the principle that pollution can be controlled and that the pace of climate change can be slowed. And the toolbox that is used to control pollution is usually, in most countries, it's based on law, and then policy, technology, regulation. Also incentives are increasingly part of the package. Incentives, for example, to encourage people to transition to renewable energy. And our commission, our Lancet Commission, offered the opinion that these solutions are ready today to be taken to a global scale. And that if they're adopted on a big scale, they will slow the pace of climate change, they'll improve health and prevent disease, and yield major cost savings. And these various forms of clean energy have become very cost effective. And their market share is increasing. So the market share of wind and solar has increased almost 500% in the past decade. It's gone from 4% of the global market to about 20% of the global market in electricity is now provided by wind and solar. At the same time, the costs have come way down. The cost of producing energy from solar panels has fallen by almost 90% because of the economy of scale. And the cost of producing electricity from wind has fallen by about 50%. And then there's the need to stop producing wastes, transition to a circular economy. Sometimes you hear nuclear energy offered as a solution to climate change. Well, it is in fact true that nuclear energy does not produce carbon dioxide. That's nice. But the problem is that nuclear plants produce nuclear waste. And that's inevitable no matter how well the plant is designed. And then every now and then, as in Chernobyl, as in 3 Mile Island, as in Fukushima, you have a major failure in a nuclear plant with massive disasters. I just don't think, I think that the nuclear option really should be taken off the table, and it's not a solution to the climate crisis, especially now that the costs of producing electricity from wind and solar have fallen so drastically. The great economic benefits of pollution control are these. The EPA, under the Obama administration, did a nice economic analysis, and they found that every dollar invested in the control of air pollution since we passed the Clean Air Act in this country has yielded about $30 in benefits. And likewise, the removal of lead from gasoline has added billions of dollars to the economy because it reduces lead exposure to children. Children then have higher IQs, and people with higher IQs are more economic, more creative, more intelligent, more economically productive, and they generate greater national wealth. And here's you'll sometimes hear the claim that pollution control kills jobs. It's going to stifle the economy. We heard that a lot, I'm afraid, in this country in the past 4 years. But the reality is just very different from that. So what you see here in this graph, which was in the New England Journal about 4 years ago, is that here are pollution levels, this lower line here, going from 1970 to almost the present. Going from 1970 to almost the present. You see that pollution in this country, air pollution, has come down by 70%, as I've noted already. And in the same time, this upper sort of lime green line here, the gross domestic product, the measure of the health of the national economy, has increased by 250%. So anybody who tells you that pollution control is killing the economy is just making up their facts. It might be good politics, I don't know about that, but it's not good science and it's not good economics. So what are the conclusions here? As we move forward in countries around the world to control climate change, to control pollution, we need to focus on health. We need to focus on advancing equity. Those should be the two goals of any national programs to control pollution and control climate change. Economic growth that accepts pollution, it's not just. It's going to make people sick, but it's also short-sighted. It's not sustainable. Right now we see the fossil fuel industries scrambling as fast as they can to build infrastructure, to lock people in here in the greater Boston area. They've recently, Enbridge, Canadian Pipeline Company, has recently completed a large natural gas compressor station in North Weymouth. Another group of fossil fuel companies wants to build a fossil fuel generating plant in Peabody, Massachusetts, in a low-income community. Always, pretty much without exception, these facilities are dumped into low-income environmental justice communities. It's not just, it's running against the tide, but what these companies are going to try to do is lock us in to fossil fuels for as many years as they can get away with, and that's why we have to make the transition as rapidly as we can possibly do it. The key is not technology. Of course, there's always room for technological improvements, but we have a lot of good technology in hand already for wind and solar energy. And the issue is really that we need leadership at the national level, at the state level, and locally. And civil society, the public need to get involved. Because if the public demands clean energy and demands an end to climate change and demands an end to conclusion, politicians will listen. And that's why we who are in the health professions are so important, because we remain trusted figures in society. If we come to understand that pollution and climate change are important causes of disease and death, and that pollution prevention and climate change mitigation are going to improve people's health, if we vigorously put out that message, people will, a lot of people at least, will believe us and take action accordingly. And of course, obviously, all of these programs need sustainable funding. So we've got a program at Boston College. I have to boast on it for just a second as I wrap up here. We've got a program called the Global Observatory on Pollution and Health. We're tracking these issues, pollution, climate change, and their health effects. We're working hard to push the findings out And we're working with cities and countries to take on these issues and do something about it. And these are some of the studies we've recently done. Air pollution in India, which is killing 1.67 million people a year. A big report supported by Prince Alvin of Monaco and the Monaco Scientific Center on human health and ocean pollution. And we had an editorial in the New England Journal of Medicine earlier this year on the false promise of natural gas that Howard Fromkin and Britta Lundberg and I wrote together. And this was triggered by the natural gas compressor station in North Weymouth, which is pictured here, right on a floodplain, right adjacent to Hingham Bay, which is a portion of the greater Boston Harbor. And we concluded in that editorial that natural gas is a fossil fuel. It's not a bridge fuel. It may generate less particulate pollution than oil or coal, but it still generates carbon dioxide. It still drives climate change. It is not a solution. It's not a bridge to anywhere. And with that, I say thank you. And I will stop screen sharing, and we've got some time, I think, for Q&A, which I'm happy to take.
Barbara, you're on mute.
Oh, thank you very much. Yeah, thank you very much for that very informative and comprehensive presentation, Dr. Landrigan. There are several great questions, and it's very informative, and I appreciate all the work that you have put into this very valuable topic. Can I present the first question? It is about why don't we see more hospitals and healthcare systems like MGB using solar energy?
I think that's a great question, and one that needs to be answered on the ground, not just with words. Healthcare sector accounts for almost 1/5 of all the energy consumption in this country. The hospitals are enormous consumers of energy, and of course hospitals need energy. We're doing high-tech stuff, operating rooms, newborn nurseries. Nobody wants hospitals to go on an energy budget where they can't provide services. But that doesn't mean that hospitals need to use energy that comes from coal and oil and gas. I think there's a very, very strong case to be made for hospitals to switch to clean sources of energy, and at the same time take all the steps that they can to be energy efficient. And of course, at the end of the day, energy efficiency actually benefits the bottom line. Anything that can be recycled and reused doesn't have to be repurchased. Anything that reduces the production of red bag waste saves hospitals lots and lots of money. So I think there's a very strong argument for pushing the healthcare sector to go to clean energy.
Thank you for your answer. I agree. The next question: in the estimates of global deaths attributable to air pollution reported by the Lancet Commission, what is the counterfactual? Is it a world without any pollution whatsoever, or rather a world with limited levels of pollution that can be realistically achieved with policy and regulations?
I would have to go back into the global burden of disease algorithms to answer that one precisely. I don't want to take a guess at it here. I'm sorry.
All right, thank you very much. The next one is, how can information about the health impacts of pollution be better incorporated into the medical curriculum? Doctors are surprisingly unaware about many of these associations between pollutants and the diseases they care for.
Yeah, you're absolutely right. So, for example, when cardiologists and internists talk about the enormous decline in deaths from cardiovascular disease that's occurred in this country since the 1950s, they always begin the conversation by talking about the Framingham study, the wonderful Framingham heart study. And they point out that it was the Framingham study that identified the connections between heart disease and tobacco, hypertension, obesity, high cholesterol, and all the other metabolic and behavioral risk factors that we all recognize that are totally incorporated into medical practice today. And almost totally missing from that narrative is the recognition that levels of air pollution in this country came down by 70% at the same time as rates of tobacco use were going down, as cholesterol was being controlled by Lipitor, as hypertension was being controlled. And the result is that when physicians give anticipatory guidance to patients, they talk to them about stopping smoking and changing their diet and getting exercise, but they don't talk about reducing air exposure to pollution, and that's a gap. So in an effort to close that gap in knowledge and in practice, a colleague, Sanjay Rajagopalan, who's a cardiologist at Case Western, we used to be together at Mount Sinai. Sanjay and I have just had accepted in the New England Journal of Medicine a nice little review article called Pollution and the Heart. It'll be coming out sometime in the next couple of months, I'm not sure when. Be on the lookout for that, because in that article, we're going to talk about the ways and means by which pollution causes heart disease and increases cardiovascular risk factors. And we're also going to make a series of recommendations, both for clinical practice in terms of anticipatory guidance to patients that aims at reducing pollution exposure, but also we're going to offer some recommendations about what physicians can do collectively, physicians, nurses, and other healthcare providers can do collectively to change the way that our country looks at pollution. And some of you will remember that there's a historical precedent for what I'm talking about here, and that is that back in the 1960s and 1970s, a group of physicians, beginning with doctors at Harvard Medical School, Dr. Bernard Lown over at the Brigham, founded the Physicians for Social Responsibility, and then the international organization that was related to that, the International Physicians for the Prevention of Nuclear War, the IPPNW. And those organizations were enormously successful. Thousands of healthcare providers got energized and knowledgeable about the horrors of nuclear war, and pressed on members of Congress and senators and presidents in this country and in Russia and in other countries to back away from the nuclear brink, and the various nuclear arms reduction treaties were signed within a very few years, and IPPNW won the Nobel Peace Prize for their work. Well, there's need now for those of us who care about these matters, for those of us who are the health professions, to do the same thing about pollution and climate change. We've got to band together. We've got to persuade our patients. We've got to persuade policymakers. We've got to persuade the public that all of these issues, pollution and climate change, are threats to health, that we can no longer tolerate them. And that means passing laws. It means controlling emissions from the healthcare sector. It means stopping the rapid, ill-considered build-out of the natural gas infrastructure.
Thank you very much. I have another question that's referring to the energy options. Please discuss energy storage technology, as this is essential for a reliable source of energy from wind and solar sources, such as battery research.
Yeah, so storage technology and grid technology are major topics of research today, because we know how to capture solar energy in the panels. We know how to capture wind energy in the windmills. The trick is to store it and to efficiently transmit it across the country, especially since the sun doesn't shine at night, the wind doesn't always blow. You have to have ways to even out the load. And my understanding is that a major component of President Biden's infrastructure bill, which is before the Congress right now, is to build out storage capacity, upgrade the electrical grid to make it feasible to achieve energy transition as rapidly as possible.
Thank you very much. Another question, what standards would you follow for screening new chemicals for toxicity? How do you predict things that may become apparent decades later?
Well, no screening system is perfect. but the current screening system we have is almost non-existent. Right now, fewer than 20% of the high volume chemicals that are on the American market have ever been tested for toxicity or safety. There's just this enormous gap in knowledge about most of the chemicals that are on the market. So there are really two things that need to be done. The first thing is that going forward, all new chemicals that the chemical industry wants to bring to market have to be screened. You know, every drug is very carefully screened. They go through FDA, multiple levels of screening, expert panel review. By contrast, industrial chemicals, consumer chemicals, basically submit a piece of paper to the Environmental Protection Agency, they get a wave and a wink, and the chemical is on the market. It's a ridiculous system. And it needs to be improved by, number one, requiring that every new chemical be screened, and number two, that existing chemicals, we have to go back and screen them, starting with those in widest use, those where there's the greatest suspicion of danger. The European Union has put in place legislation called the REACH legislation, and a fundamental principle there is no data, no market, meaning that if there is no data on the safety or the toxicity of a chemical, it doesn't get to market. We have to do the same thing here in this country, and I hope the Congress will have the courage and the common sense to do that in the coming years.
I hope so as well. I have a question on ambient air pollution. Why has the ambient air pollution science community not yet recognized the central biological pathway that drives particulate health effects and unifies progression of all diseases driven by inflammation, the NLRP3 inflammasome? The science has been pretty clear since 2008, even though inflammasome biology really did not start until 2000.
Yeah, well, inflammation, oxidative stress are important pathways in the genesis of disease caused by air pollution. That's absolutely correct. I think it's reasonably well recognized. There are other pathways as well. Some of the particulates that people inhale when they inhale particulate air pollution contain toxic heavy metals, and those metals further exacerbate the toxicity.
I have a question. What more can local leaders here in Massachusetts do? Most of our constituents already support efforts to reduce the use of fossil fuels. How can we effectively leverage the influence of our constituents on a national or global scale?
That's a great question. And I think what you see, and you see it right here in Massachusetts, is there is a gap between people's desire for clean air and clean energy and the policies that are being rolled out at the state level. It really doesn't make a lot of sense in a logical world to be building a natural gas compressor station in North Weymouth. It doesn't make a lot of sense to be building an electric generating plant in Peabody, Massachusetts that's powered by fossil fuels, not when it's actually cheaper to generate electricity from wind and solar. So you have to ask who benefits, who's getting the economic benefit from these irrational choices. And I think people have to rise up. They have to speak to their elected officials. They have to say no more. This doesn't make sense. It's going to result in disease and death, especially for children and other vulnerable populations. And I think we have to send a message through the ballot box to our elected officials that we want this madness to end. That's why, again, coming back to something I said a few moments ago, that's why the role of healthcare providers is so important, to educate the public, to make your patients realize that pollution is causing disease and it's killing them.
There are so many questions left over. Do I have time for another one?
I can do one more, but then I'm going to have to go.
Oh, thank you so much. This was probably really relevant for many parents. Is there any literature linking the increased incidence of autism to be linked with pollution exposure of women either before or during pregnancy?
Yeah, well, there have been a number of studies that have looked at what are the factors responsible for the increase in autism. Lead has been linked to autism. Certain consumer chemicals like phthalates and bisphenol A have been linked to autism. traffic-related air pollution has been linked to autism in very carefully done epidemiologic studies. And there have also been a number of studies that have looked at the link between, the reported link, I should say, between vaccines and autism. Those studies have found no connection whatsoever between vaccines and autism. It's clear that the increase in autism is far too rapid to be of genetic origin. It's something in the environment, but we don't have the whole story yet.
Dr. Landrigan, thank you very much for your presentation. It has been very informative and very relevant for many of our participants, and there are still many questions, and we'll probably try to get to something. Winnie, do you have anything to add?
No, thank you. That was fantastic. And there were everyone had a lot of questions. I'm sorry we didn't get to all of them. We appreciate your time so much. Again, this link will be sent to our registrants. So if you didn't catch everything, don't be alarmed. You can see the beginning at home in the comfort of your home. So thank you, everybody. And I'm going to stop the recording and end this. Thank you so much, Dr. Landrigan.
Thank you, Winnie. Thank you, Barbara. Thank you, Patrice.
It was a great presentation. Thank you.
Thank you.
You're welcome. It was fun. It was good.